Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and in today's lecture, we will be discussing general principles of head and neck radiation therapy. The first video that I released in the head and neck cancer series went through the different disease sites that are covered in terms of head and neck cancer, and each of these disease sites has its own staging system and its own treatment paradigm. So in future talks, we'll definitely be getting into the nitty-gritty details of each individual disease site. In this overview talk, going over general principles of head and neck radiation, what I'd really like to do is address some general overarching principles of radiation and chemoradiation therapy that apply across the board to all disease sites. Now, there are some exceptions, and I'll try to make note of what those exceptions are as we go through things, but for the most part, head and neck cancers are either treated with definitive radiation therapy, and if they have certain risk factors, we think about adding concurrent chemotherapy, or they are treated with surgery followed by tailored adjuvant treatment. If patients are low risk, they can typically be observed, but if they have higher risk factors, then we think about adding adjuvant radiation therapy in the post-operative setting. And if they have some additional high-risk features, we actually think about adding concurrent chemotherapy to their post-operative radiation. So in this talk, what I'd like to do is kind of step-by-step go through some of the data that talks about our dosing for radiation, the fractionation that we use, and considerations for adding systemic therapy, both in the definitive setting and in the post-operative setting if patients get surgery. So this is a very overarching talk, and I know we haven't kind of one by one covered the disease sites just yet, but the principles that we go through in this lecture will kind of broadly apply across all of the disease sites. So let's get started. We'll start by talking about radiation fractionation schemes in head and neck cancer. So when we're treating with radiation in the definitive setting, that means these patients are getting definitive radiation as their local therapy and they are not planning to undergo any type of surgery. In this situation, the most standard dose that we deliver is 70 gray in 35 fractions. And in the IMRT era, we typically deliver this radiation as a simultaneous integrated boost. So 70 gray, which is the highest dose, is typically what goes to the primary tumor and any involved nodal disease. And then there are lower dose levels for lower risk regions. So there's typically an intermediate risk volume, which often gets a dose somewhere around the neighborhood of 63 gray in 35 fractions. And that is to a mucosal margin on the primary tumor, as well as involved nodal levels. So for example, if you have a base of tongue cancer, which is an oropharyngeal disease site, so if you have a base of tongue tumor and say a level 2 node, so the tumor itself and the involved node would get 70 gray, and then an additional mucosal margin on the primary tumor and the entirety of level 2, which is involved, would go to 63 gray. And then the remaining nodal levels on that ipsilateral side of the involved node would get 56 gray, as would the contralateral neck. So that's kind of how we approach the dosing in head and neck cancer. So usually it's something like 70 gray in 35 fractions, and then 63 gray to a margin and involved nodal levels, and then 56 gray to your elective nodal volume, which is not involved with disease, but it's something that we're covering because we know that head and neck cancer has rich lymphovascular spread and there's a high risk of involvement. These are, again, general dosing guidelines. Individual practices may vary, and it's not always 70, 63, 56, and 35 fractions. There are many variations, alternative fractionation schedules that exist. I'm just sort of giving one example of something that is an accepted standard. An important exception to this fractionation scheme is early stage cancers of the glottic larynx. So in the glottic larynx, we can have tumors that are just confined to the vocal cords, and these tumors are treated very differently than any other head and neck cancers because unlike most sites within the head and neck, The glottic larynx actually does not have a very rich lymphatic network, and so the risk of nodal spread is very, very, very low. And so we typically will just treat the larynx alone when we're dealing with early stage glottic larynx. And there are some studies which we'll talk about in our laryngeal cancer talk that show that a moderately hypofractionated radiation approach is better for tumors that are early stage glottic larynx tumors. So T1N0 glottic larynx tumors are typically treated with 63 gray and 28 fractions at 2.25 gray per fraction. And for T2N0 glottic larynx cancers, we typically just add one extra fraction. So it's still 2.25 gray per fraction, but instead of 28, we do 29 fractions for a total of 65.25. So most of the time when we think about the definitive radiation dosing for head and neck cancer, we're in the neighborhood of 70 gray and 35 fractions. And then the biggest exception to this rule is early stage glottic larynx, where we typically do 2.25 gray per fraction for a total of 28 to 29 fractions. And again, important note that many, many variations can exist in this. So sometimes people can do a sequential boost, something like 50 gray, then 60 gray, then 70 gray, all at 2 gray per fraction. We'll talk about data for hyperfractionation, where we do 6 fractions per week rather than 5 fractions per week. There are also regimens that use 33 fractions, so slightly hypofractionated. So again, many variations, but if you say 70 gray and 35 fractions is your definitive radiation dose, you won't be faulted. And again, the only exception to that rule is early stage glottic larynx, where we do 28 to 29 fractions at 2.25 gray per fraction. Let's pause there for a minute and take a look at some of the evidence for why we dose the way that we do when it comes to definitive radiation. The most classic trial in head and neck cancer that looked at different fractionation regimens is the trial known as RTOG 9003. This is a historical fractionation trial, but it looked at patients with different types of head and neck cancer, including oral cavity, oropharynx, larynx, hypopharynx, and it randomized them to 4 different fractionation regimens for treatment of their cancer. This is a very old trial. It was first published in the year 2000, and the 4 different regimens that they used were, number 1, standard fractionation, which is 70 gray and 35 fractions over 7 weeks, so 5 fractions a week. They also looked at hyperfractionation, where they gave 81.6 gray and 68 fractions BID, so twice daily treatment over 7 weeks. Then there was a split course accelerated fractionation arm that gave 67.2 gray in 42 fractions BID over 6 weeks with a 2-week break halfway through. And then there was an accelerated fractionation with concomitant boost, where they gave 72 gray and 30 fractions over 6 weeks, plus an additional boost field with 1.5 gray per fractions for the last 12 treatments, just to the primary and the gross nodes. So this is a very old trial, and so there are some major caveats to be aware of, including that this was done in the pre-IMRT era. There was also no concurrent chemotherapy offered to these patients. But the key takeaways from the trial is that the initial results showed improved local regional control with the hyperfractionation arm, as well as the accelerated fractionation with a concomitant boost arm. They also found that there was improved overall survival with hyperfractionation. So that was the BID treatment, 68 treatments BID over 7 weeks. The long-term analysis ended up showing the best toxicity outcomes with hyperfractionation, which makes sense because long-term toxicity is typically a function of dose per fraction. And when we're doing BID fractionation, we're giving less dose per fraction. So they had better long-term toxicity. And the local regional control and overall survival benefit really persisted only with the hyperfractionation arm. So RTOG 9003 is a very historical and outdated trial, but what I think the key takeaways are is, number 1, it's important to know that the 4 different arms were looking at different fractionation regimens and exactly what those arms were. Hyperfractionation was the winning arm on this trial, so that was the BID regimen of 68 fractions over 7 weeks. And the other important takeaway, I think, is to realize is that split course radiation was investigated and it was very attractive, I think, in this older era because it allowed patients to have less toxicity. But while split course radiation allowed time for the skin to heal, it also actually allowed time for the tumor to regrow. And as we've seen, even in vulvar cancer, split course radiation is really not desired. We don't like to have a long break in the chemotherapy. And so these, in my mind, I think, are the biggest takeaways from RTOG 9003. We just talked about this a little bit with the split course fractionation, and there's another study by Withers et al., I'm just calling it the Withers study, that really highlights the importance of minimizing treatment breaks for our patients that are getting radiation for head and neck squamous cell cancers. So squamous cell carcinomas are really fast-growing tumors, right? And so when we introduce these long treatment breaks, yes, it's good from a toxicity standpoint because the skin has time to heal, but it's really bad from a local control standpoint because it also means that the cancer has time to regrow. And this Withers study is very old, again, published in 1995, but it was a retrospective study of patients treated with radiation for tonsillar squamous cell cancer. And in the analysis that they did, they found that the overall treatment time really, really matters. So each day that radiation was delayed resulted in a 1% decrease in local control. And that's a number that I've seen quoted directly to patients. We don't want to have long breaks in radiation. One day here or there, if a machine breaks down or if there's a snowstorm or something like that, is okay. But if we introduce these long breaks, then we really start to impact the local control in a negative way. So each day that radiation was delayed in this study, there was a 1% decrease in local control. And they found that the dose matters. So for each gray that they added, when there were breaks, there was about a 2% gray increase in local control. And so from there, they recommended that if patients have radiation delays, then they recommend prescribing an additional 0.5 to 0.7 gray for each day that radiation is delayed to maintain that same level of local control. So that's something to be aware of. When we're treating our patients with head and neck cancer, life happens, things happen. These patients often get sick, requiring feeding tubes, hospitalization, so on. Each day that radiation is delayed, however, there is a 1% decrease in local control. So it's really important for us to try to push through and minimize treatment breaks as much as we can. And if we do end up with a long treatment break, then dose matters as well, and we might consider prescribing additional dose to make up for that time that radiation was delayed. So a key takeaway, again, from RTOG 9003 and also supported by the Withers study is that overall treatment time really matters in head and neck cancer. And we definitely want to minimize treatment breaks, so we don't want patients to take longer than they need to. But on the flip side, the question is, well, can we actually improve outcomes by shortening the overall treatment time by delivering more fractions within a shorter period of time? And so the DHANKA study, DHANKA 6 and 7, is a Danish study. And this looked at patients with different head and neck cancers that were treated with primary radiation. And they randomized them to either 5 fractions per week or 6 fractions per week. So with 5 fractions a week, they were treated over a total of 7 weeks. Or with 6 fractions a week, they were treated with the same number of fractions, but instead of 7 weeks, they were treated in 6 weeks total. All of the patients, except for glottic cancer patients, actually also were treated with a hypoxic radiosensitizer known as nemorazole. And in the DHANKA study, they found that there was improved local regional control and disease-specific survival, but not improved overall survival with the 6 fractions per week regimen. So the 5-year local control was 70% with 6 fractions a week versus 60% with 5 fractions a week. And the benefit was mainly seen for primary tumor control, but not really for neck nodal control. The disease-free survival was also improved, 73% versus 66%. And again, there was not an overall survival benefit. What they did find is that there was worse acute toxicity when they squeezed it into 6 weeks total, but this eventually did resolve. So this Dahanka paradigm, I think, is important to be aware of. I believe that 6 fractions per week has kind of been adopted as a Danish standard. In the United States, I think that practices can really differ by institution. And the way that we put 6 fractions into 1 week can kind of differ by institution too. So sometimes you can either do it an extra fraction on a Saturday, or you can treat with 6 fractions by treating BID, say on a Friday. And so the approach as to how we can actually fit this in can differ. But this is an important kind of paradigm to be aware of, where we give 6 fractions a week instead of 5 fractions a week. So at this point, you're probably wondering, it seems like altered fractionation, either hyperfractionation or kind of accelerated fractionation, really seems to have a benefit over conventional fractionation. So why in this era are patients still getting treated with 70 gray and 35 fractions with 5 fractions per week? And I think the data is quite nuanced, and I think it's also confusing to wrap your head around. So I'll try to do my best at making sense of this. There's a meta-analysis of fractionation called the March Head and Neck meta-analysis that looked at multiple randomized trials, and they basically drew 2 comparisons. So the first comparison they did was primary or postoperative conventionally fractionated radiation versus altered fractionated radiation. And then the second comparison that they did was conventionally fractionated radiation with concurrent chemotherapy versus the altered fractionation of radiation. And they looked at 3 types of altered fractionation and kind of lumped them into one group. So hyperfractionated, accelerated fractionation, and very accelerated fractionation were all kind of grouped as altered fractionation. So in the first comparison with no chemotherapy, it was just altered fractionation versus conventional fractionation. Altered fractionation was associated with improved overall survival. They found a 3% improvement in the 5-year overall survival and a 1% improvement in the 10-year overall survival. And on subset analysis, only the hyperfractionated radiation regimen was associated with an overall survival benefit. The second comparison looked at conventional fractionation with concurrent chemotherapy versus altered fractionation. And in this arm, what they found is that the chemoradiation arm with conventionally fractionated radiation was the winner, associated with about a 6% 5-year overall survival and a 5% 10-year overall survival benefit. So hyperfractionated radiation alone led to worse survival than conventionally fractionated radiation when given with concurrent chemotherapy. So the one comparison that is lacking is hyperfractionated radiation with or without chemotherapy. But I think the big takeaway from this meta-analysis is that when we are giving chemotherapy, then the benefit of hyperfractionation kind of goes away. And at that point, you might as well do conventionally fractionated radiation. The other thing I think it's really important to keep in mind, it's nice that we have hyperfractionation and we know that this has a small benefit in overall survival, but it's also important to keep the patient in mind, right? A lot of the head and neck cancer patients that I've seen, they have a hard enough time coming in every single day for 7 weeks. If we ask them to come in BID for that entire time, or if we ask them to come in more than once a day for a given week, it becomes really hard on them and it's tough for them to do. So that's, I think, another huge consideration in our approach to fractionation is what's really feasible for our patients. So I do think this is an important takeaway, though, that when we're giving chemotherapy concurrently with radiation, the benefit of altered fractionation seems to sort of go away. And so conventionally fractionated radiotherapy with concurrent chemotherapy is a standard. Hyperfractionated radiation is also an option. Here are 2 additional randomized controlled trials, GORTEC 9902 and RTOG 0129, and they both looked at similar questions, comparing in the setting of chemotherapy, conventionally fractionated radiation to altered fractionation. And what they found is that when we're giving concurrent chemotherapy, there's no difference between conventional fractionation and hyperfractionation. And based on GORTEC 9902, they had a very accelerated fractionation arm where they gave BID fractionation and delivered all the radiation within a period of 3 to 5 weeks only. But there was no chemotherapy delivered in that very accelerated arm. So when they compared very accelerated radiation over 3 to 5 weeks to conventionally fractionated chemoradiation was still the winner. And so very accelerated radiation does not compensate for a lack of chemotherapy. So circling back then to the general dosing that we use for definitive radiation. For most disease sites in head and neck cancer, 70 gray and 35 fractions is a standard approach. And oftentimes we deliver this as a simultaneous integrated boost, and we have 3 different dose levels. So there's a high risk, intermediate risk, and a low risk volume. The biggest exception to this rule is, as we said, early stage cancers of the glottic larynx. So T1 to T2 glottic larynx cancers are treated in 28 to 29 fractions at 2.25 gray per fraction. The alternate fractionation regimens that we talked about a little bit, I'll try to touch on them and kind of talk about when those are indicated. So most of the time with IMRT, it's better to do a simultaneous integrated boost because it helps to minimize the low dose spread. But sometimes we can consider a sequential boost at 2 gray per fraction. Some people will consider that if there's no chemotherapy being given. I've also seen it used in the situation where there's a very, very large primary, and we're hoping to kind of replan after that primary tumor shrinks a little bit. So sometimes it might make sense to use a sequential boost rather than a simultaneous integrated boost. Hyperfractionation can be used, so you can think about 6 fractions per week like in DeHanka, or BID fractionation. Some people actually do use 6 fractions per week standardly. Oftentimes, I've seen some people consider it if we're not giving any concurrent chemotherapy. And then in the setting of reirradiation, I know a lot of folks prefer BID fractionation because it's a little bit easier from a toxicity perspective. And so there are different indications where you might consider hyperfractionation. And then finally, some people will actually standardly utilize mild hypofractionation for all head and neck cancers, where instead of giving 70 gray in 35 fractions, they actually give 70 gray in 33 fractions. So when we're giving it in 33 fractions, rather than giving 2 gray per fraction, it's 2.12 gray per fraction. So it's very, very mild hypofractionation. So like I said at the beginning, there are a lot of caveats. There are a lot of, I think, variations in practice and how people will actually do things. But I think it's good to be aware of acceptable standards. And again, I think if you were to say 70 gray and 35 fractions, you really would not be faulted for the vast majority of head and neck cancers. This is a nice table showing the high, intermediate, and low risk dosing that's used across various protocols and guidelines. So they have the NCCN guidelines on here, as well as the protocols from different NRG trials. And as you can see, the high risk volume typically gets 70 gray in 35 fractions. The intermediate risk gets something along the lines of 60 to 63 gray. And then the low risk gets something like 52.5 to 56 gray. So 70, 63, and 56, all delivered in 35 fractions, is a very commonly accepted standard. And so I think that those are good numbers to keep in mind. So we talked about definitive dosing for head and neck radiation, and we talked about some of the evidence from where we get that dosing. Post-operative radiation is typically indicated for patients that have undergone surgery for their head and neck cancer who have certain high-risk features. So if they are low risk after surgery, they can typically just be observed. But if they have certain high-risk features, such as pathologic T3 to T4 disease, N2 to N3 disease, extracapsular extension, close or positive surgical margins, LVSI, or perineural invasion, these are really the indications for which we consider adding post-operative radiation. So not all patients will need post-operative radiation, but a lot of times they do end up needing it because inevitably they have one of these risk factors, which is PT3 to T4 disease, N2 to N3 disease, extracapsular extension, close or positive margins, LVSI, or PNI. So if they have one or more of these factors, they inevitably will require post-operative radiation. So the doses that we use in the postoperative setting are less than what we use in the definitive setting, because in the postoperative setting, what we're really trying to do is clean up any microscopic disease that might have been left behind. So the standard dose that we use in the postoperative setting is 60 gray in 30 fractions. And once again, we typically deliver this as a simultaneous integrated boost, or a SIB, delivering 60 gray to the tumor bed and then 1 or 2 additional lower dose levels. So at my institution, what I have often seen is 60 gray to the tumor bed, 57 gray to the entire operative bed that includes the dissected neck, and then 54 gray to an additional elective volume. So oftentimes that'll be kind of the contralateral neck. You can also just use 2 different dose levels, so something like 60 gray and then 56 gray, all delivered in 30 fractions. For patients that have a positive surgical margin or extracapsular extension, that means that we are genuinely concerned that there is microscopic disease that has been left behind. And so for this, we typically will add an additional boost and take these up to 66 gray. Now we still go at 2 gray per fraction, so if we are boosting for a positive surgical margin or extracapsular extension, we typically just add an additional 3 fractions and do 6 gray and 3 fractions for a total of 66 gray. So we treat everything as above, 60 gray and 30 fractions with the intermediate and low dose levels, but then we add an additional 6 gray and 3 fractions as a sequential boost, only for positive surgical margin or extracapsular extension. Because remember, those are both indications that there's actually microscopic disease that was left behind, and so we need to boost that. There's only a couple of trials that I want to highlight for postoperative radiation, and I think they're a little bit easier to wrap my head around compared to the data for definitive radiation. There's a very old trial, RTOG 7303, that randomized patients to either get preoperative versus postoperative radiation for their head and neck cancer. So preoperative radiation was given to a dose of 50 gray at 1.8 to 2 gray per fraction, and then the patients went on to get surgery within 4 to 6 weeks. Or they were randomized to surgery followed by postoperative radiation within 4 weeks, and they got 60 gray to the primary and 50 gray to the remaining neck. And remember, this trial was started in the 70s, so they were not using IMRT, and so they were using kind of a sequential boost with 3D planning. So 50 gray to the low risk volume and then 60 gray boost to the primary. What they found is that there was significantly improved local regional control with postoperative radiation. So the local regional control was 70% with postoperative radiation versus 58% with preoperative. And in both groups, local regional failure accounted for about 60% of failures within the first 2 years. They didn't see any significant difference in survival between the 2 arms, but based on that significant improvement in the local regional control, RTOG 7303 kind of established postoperative radiation as the standard for patients that were managed with surgery. And then there's a nice study from MD Anderson that looked at a risk-adapted approach to postoperative radiation and also established some nice guidelines around dosing. So this was a prospective multi-institutional study, and they basically grouped patients into risk based on the number of adverse factors that they had. So the adverse factors were having an oral cavity primary, the status of the mucosal margin, having perineural invasion, a single positive nodes, greater than 1 positive nodal groups, a node that was larger than 3 centimeters, and a treatment delay of over 6 weeks postoperatively. So if they had none of these risk factors, they were classified as low risk and they were not treated with any postoperative radiation. If they had only one of these adverse factors, they were classified as intermediate risk and they were treated with 57.6 gray over 6.5 weeks. And if they had 2 or more adverse factors, they were classified as high risk and they were treated with 63 gray over 5 weeks. And the 5-year local regional control, as well as the 5-year overall survival for each of these low, intermediate, and high risk groups are shown in the table. And as you can see, obviously as the risk increased, the local control and the 5-year overall survival dropped off. But the patients that had no adverse risk factors that were low risk and were managed with just observation after surgery, they had pretty high rates of 5-year local control, so 90%, and the 5-year overall survival was the best of all of the groups at 83%. They also looked at fractionation, and they found that hyperfractionation did not seem to show a significant benefit in the high-risk group, but it did seem to make up for some of that delay in patients that had more than 6 weeks treatment delay. So the MD Anderson study justifies this risk-stratified approach to postoperative management of our head and neck patients that get upfront surgery. And again, it shows that the hyperfractionation was not too beneficial. So I really don't have too many studies listed here on accelerated hyperfractionation in the postoperative setting. But there is another Italian trial that's similar to this MD Anderson study that shows that accelerated fractionation is probably not beneficial overall, but it might be an option for patients that delay starting radiation. It might seem to make up for a little bit of that delay. So again, Italian study corresponding to the findings of this MD Anderson study. Just to review, let's once again go through some of the general indications for postoperative radiation. The criteria that I have listed here are actually from the RTOG 0920 trial. This was a negative trial. It looked at postoperative radiation with or without cetuximab for intermediate risk head and neck squamous cell cancers, and the addition of cetuximab did not actually show a benefit. But the patients that they accrued to this trial are the patients that we should be thinking about for offering postoperative radiation alone. So post-op radiation without chemotherapy. So the criteria that we would use are T1 to T2, N1 to N2 disease, or T2 to T4A, N0 to 2 disease, who have had gross total resection and have one or more of the following risk factors. So PNI, LVSI, a large node greater than 3 centimeters, or multiple nodes, so 2 or more nodes. If they have a close margin that's less than 5 millimeters, or a positive margin that had to get re-excised and then was negative. If they have a PT3 to T4 primary, or if they have an oral cavity T2 tumor with greater than 5 millimeter depth of invasion. So these are just some general guidelines to keep in mind, and this is when we should be thinking about offering our patients postoperative radiation. And once again, just to review, typically the dosing that we think about in the postoperative setting is 60 gray, and we often deliver this as a simultaneous integrated boost. And we can have 2 or 3 low to intermediate risk dose levels, so we can do 60, 57, 54 in 30 fractions, or 60 gray and 56 gray in 30 fractions. And if patients have a positive margin or extracapsular extension, so basically microscopic disease that we know has been left behind, then we add an additional 6 gray and 3 fractions sequentially for a total of 66 gray and 33 fractions. Now, in terms of radiation technique for head and neck cancers, whether we're doing definitive radiation or postoperative radiation, IMRT planning is really the standard of care. A lot of these older studies that we talked about use 3-dimensional planning, and so that is an important caveat to keep in mind when we're looking at their toxicity results. But in the modern era, IMRT is much, much better at shaping the dose, curving it out of our critical organs, and minimizing side effects. So the best data for the benefits of IMRT is really in the area of xerostomia due to parotid gland sparing. There's a study from the University of Michigan that looked at the mean dose to parotids in between IMRT and 3D planning. And the mean dose to the parotid glands was 20 gray with IMRT versus 57 gray with 3D planning. And the 1-year recovery of salivary flow was 63% with IMRT versus only 3% with 3D planning. There was another study called PARS Sport looking at parotid sparing IMRT, and they found that at 1 year, the rate of grade 2 or worse xerostomia was 40% with IMRT versus 74% with 3D planning, so literally cut in half. So much, much better xerostomia. Other theoretical benefits of IMRT are improved dysphagia due to pharyngeal constrictor sparing, decreased osteoradionecrosis due to mandible sparing, improved sensory neural hearing preservation because we can spare the cochlea, and we can also better spare the brainstem. This table is just for reference, but these are some helpful dose constraints that I have seen used for IMRT for head and neck plans. Some of the most important doses on here, I would say, are the mean dose to the parotid glands. We try to keep that less than 26 gray. The mean dose to the pharyngeal constrictors, oral cavity, carotid arteries, all of that we try to keep less than 56 gray. Mean dose to the cochlea, we try to keep less than 35 gray, and the larynx and submandibular gland also, we try to keep mean less than 35 gray. So hopefully this table is a little bit helpful. So that was a ton of information about the radiation aspect for managing head and neck cancers. Remember, head and neck cancer patients are either managed with their definitive local therapy as surgery or as radiation. If they're getting definitive radiation, then the standard dose is 70 gray. And if they are getting post-operative radiation, well, they first go for surgery, and only if they have certain risk factors do we think about adding post-operative radiation. And if we're doing post-op radiation, the standard dose is 60 gray, but if they have positive margins or extracapsular extension, then we boost that to 66 gray just to get rid of that microscopic disease. So that's radiation in a nutshell. What we're going to do now is switch gears and talk about when do we add concurrent chemoradiation. And as we will see, there are different indications to add it in both the definitive setting as well as in the post-operative setting. When we give concurrent chemotherapy, the agent that we use is Cisplatin. So we give weekly Cisplatin 40 milligrams per meter squared. That is considered a low dose Cisplatin. There's also high dose Cisplatin where we can do 100 milligram per meter squared given every 3 weeks. And as we will see, that's what was used in a lot of these studies. Unfortunately, the high dose Cisplatin tends to lead to some worse toxicity. And so at my institution, I have standardly seen just Cisplatin 40 milligrams per meter squared given once a week, just like we do in a lot of gynecologic cancer patients. And then for patients where Cisplatin is contraindicated, if they have kidney dysfunction or concerns about hearing loss, we can use concurrent cetuximab or carboplatin and paclitaxel. So cetuximab, carbotaxol are options if Cisplatin is contraindicated. In the post-operative setting, the biggest indications to add concurrent chemotherapy are for patients that have positive surgical margins or extracapsular extension. In the definitive setting, we typically think about adding concurrent chemotherapy if patients have more locally advanced disease. So if they have clinical T3 to T4 disease, or if they have N2 or higher disease, then we add it in the definitive setting. And again, these are highly, highly generalized principles. And in reality, your management is really going to take into account many different factors, including the disease site, the institutional standard, individual patient considerations. They can definitely have other risk factors that push you towards adding chemotherapy besides just what I have here. But again, for board purposes and kind of textbook answers, in the post-operative setting, your indications for concurrent chemotherapy are positive surgical margins and extracapsular extension. And then in the definitive setting, it's if they have clinical T3 to T4 or N2 to N3 disease. The last little note that I'll make here is a note about induction chemotherapy. I don't have further slides about induction chemotherapy, but there are a couple of studies I just want to mention to be aware of. So there's a study called TAX-324, and it looked at induction chemotherapy for head and neck cancers, and they randomized patients to induction chemotherapy with TPF, which is docetaxel, cisplatin, and 5-FU, versus just cisplatin and 5-FU, followed by chemoradiation therapy. So both arms got chemoradiation therapy, but they were randomized to induction TPF versus PF. And they found that adding that T, or taxotere, also known as docetaxel, improved outcomes. And so when we're doing induction chemotherapy, it looked like adding the docetaxel was a benefit. But then there was another study called TTC 2503, first author hit, And that study showed that when high-dose cisplatin-based chemoradiation is used, there does not seem to be a benefit to induction chemotherapy. And so standardly, we don't typically use induction chemotherapy for most head and neck cancers. The only time we think about induction chemotherapy is for nasopharyngeal cancers. Those patients benefit from induction gemcitabine and cisplatin, followed by radiation or chemoradiation. And then the other time that we can think about it is if patients have really, really locally advanced disease that's not amenable to upfront surgery or radiation. And we're trying to just give some chemotherapy to try and shrink things down and make them, amenable to either surgery or radiation. So those are kind of the two main times that we think about induction chemotherapy. Otherwise, if we're adding chemotherapy, it's typically concurrently with radiation. And again, in the definitive setting, it's if they have clinical T3 to T4 or N2 disease. And then in the postoperative setting, it's if they have positive surgical margins or extracapsular extension. So those are the same criteria that we would consider boosting to 66 gray. I'll try to be quicker with the evidence here, and we'll start by talking about definitive chemoradiation. There's a mock NC meta-analysis that was published in 2009, and it was a high-level meta-analysis of over 17,000 head and neck cancer patients treated across more than 90 different trials. So they combined many different types of chemotherapy together. They included many different historical trials prior to the 70s, and so P16 status was not available. But the important takeaway from this meta-analysis is that the addition of chemotherapy provided a 4.5% overall survival benefit at 5 years. And if you have a hard time remembering that chemotherapy provided around a 5% benefit, I think 5% is a good number to know because it applies not just to head and neck cancer, but also to lung cancers. In both non-small cell and small cell lung cancers, if you recall, the studies that looked at the addition of chemotherapy showed about a 5% benefit to the addition of chemotherapy. So same thing with head and neck, the addition of chemotherapy provided about a 4.5% or about a 5% overall survival benefit at 5 years. Now, concurrent chemoradiation showed the most benefit, an absolute benefit of 6.5% at 5 years, which was statistically significant. Induction chemotherapy did not show a significant benefit, only 2.5% at 5 years. And so again, I talked about kind of that HIT study that showed no benefit to induction chemotherapy with cisplatin-based chemoradiation. And same thing here, the induction chemotherapy wasn't significantly beneficial, but the concurrent chemoradiation was beneficial. Patients above the age of 70 did not seem to benefit much in terms of the overall survival. So this meta-analysis is important to know because it tells us that adding concurrent chemotherapy to radiation provides about a 6.5% overall survival benefit, and adding any chemotherapy at all, whether that's induction or concurrent, is a 4.5% survival benefit, but it's really driven by the concurrent chemotherapy with the radiation. And in terms of the indications for concurrent chemoradiation in the definitive setting, it's really something that we think about for our higher stage patients, so clinical T3 to T4 or N2 to N3. So these are our stage 3 to 4 patients. So there was an intergroup trial that took patients with stage 3 to 4 unresectable head and neck squamous cell cancers, and they randomized them to radiation alone, 70 gray and 35 fractions, versus radiation with concurrent cisplatin. And they were giving them high dose cisplatin, so 100 milligrams per meter squared every 3 weeks. And they had an additional randomization with split course chemoradiation, and they had pretty slow accrual. The trial closed early, but they found that the best benefit was seen in overall survival improvement with the conventionally fractionated radiation arm with concurrent cisplatin. And recall from the GORTEC 9902 and RTOG 0129 studies that we discussed, remember that when concurrent chemotherapy is given with the radiation, utilizing hyperfractionation or altered fractionation really does not seem to add much of a benefit. And so the definitive chemoradiation, when we give concurrent cisplatin, we typically just give conventionally fractionated radiation. And again, the indication for this is typically stage 3 to 4 disease. So clinical T3 to T4 disease or N2 to N3 disease. Moving on to discuss the evidence for postoperative concurrent chemotherapy with radiation. There are two important trials to know here. The first of these is RTOG 9501. RTOG 9501 randomized patients that had undergone surgery for head and neck cancer, and these patients had to have one or more of the following risk factors. So either 2 or more lymph nodes, extracapsular extension, or positive surgical margin. And then they were randomized to postoperative radiation alone or postoperative chemoradiation with the addition of concurrent high-dose cisplatin given every 3 weeks. What they found is that with the addition of chemoradiation across the entire cohort, there was an improvement in local regional control, but not really any difference in the overall survival. However, there was an unplanned subset analysis limited to patients that had positive surgical margins and extracapsular extension, and they found improved local regional failure rates as well as disease-free survival that were statistically significant in this subset of patients. So the local regional failure rates were 33% with radiation versus 21% with chemoradiation, so 12% improvement there. The disease-free survival improved from 12% with radiation up to 18% with chemoradiation, and the overall survival improved from 20% up to 27% with chemoradiation. So RTOG 9501 on that subset analysis really showed a benefit to postoperative chemoradiation, specifically for patients that had positive surgical margins and or extracapsular extension. The other study that's super important to know here is EORTC 22931, which is a very similar study to the RTOG 9501. So EORTC 22931 was a randomized trial, and they took head and neck cancer patients who had undergone surgery who had either clinical T3 to T4 or N2 to N3 disease, or any of these high-risk features, including positive surgical margins, extracapsular extension, PNI, or vascular tumor embolism. And again, they were randomized to postoperative radiation alone or radiation with concurrent high-dose cisplatin. And the results showed that chemoradiation significantly improved their 5-year progression-free survival and overall survival. Progression-free survival improved from 36% up to 47%, and the overall survival improved from 40% up to 53%. So somewhere on the order of 10 to 15% improvement in both of these outcomes. There was then a pooled analysis of RTOG 9501 and EORTC 22931, and on multivariate analysis, what they found is that extracapsular extension and or microscopically positive surgical margins were the only 2 risk factors that showed a significant impact of chemoradiation in both trials. And so the major takeaway from this pooled analysis is that these trials support adjuvant chemoradiation for patients that have extracapsular extension and or positive surgical margins. So if patients have extracapsular extension or positive surgical margins after surgery, we think about boosting to 66 gray, and we also think about adding concurrent chemotherapy to the radiation. The NCCN guidelines for adjuvant chemoradiation support this, and the concrete indications for adding chemotherapy to your postoperative radiation are positive surgical margins and extracapsular extension. And then there are additional high-risk factors to consider, again, based on the inclusion criteria for EORTC 22931. Remember that EORTC 22931 was a positive study. And so the risk factors that they included were multiple positive nodes, PNI, LVSI, PT3 to T4 disease, and an oral cavity or oropharynx primary with low neck involvement, so level 4 or 5 nodes involved. So if you have some of these higher risk factors and you're concerned, it's always a good idea to consult a medical oncologist and think about adding concurrent chemotherapy as well. But for test purposes, the criteria that you must know for adding adjuvant chemotherapy in the post-op setting are positive surgical margins and extracapsular extension. So that is when we think about adding concurrent chemotherapy with our post-op radiation. Now, when I first talked about concurrent chemotherapy, I mentioned that we can often use cisplatin 40 milligrams per meter squared weekly, just like we do in gynecologic cancer patients. But all of the trials that we've talked about use cisplatin 100 milligram per meter squared given every 3 weeks. So what is the deal with that? Well, traditionally, cisplatin was given with what we call a high-dose regimen. So high-dose cisplatin, 100 milligram per meter squared given every 3 weeks. But this was associated with significant toxicity. Now, there's a VA retrospective study, so a study that took place at VA hospitals, and this was a population-based study, so it's retrospective data. But they looked at patients that received either high-dose cisplatin, 100 milligram per meter squared given every 3 weeks, versus patients that got low-dose cisplatin, 40 milligram per meter squared given once weekly. What they found is that high-dose cisplatin was not associated with improved overall survival, but it was associated with an increased risk of kidney injury, neutropenia, dehydration, as well as hearing loss. So it's more toxic, but doesn't necessarily provide an overall survival benefit based on this VA retrospective study. There's another randomized study out of India that compared high-dose to low-dose cisplatin, but they used 30 milligram per meter squared weekly instead of 40 milligram per meter squared weekly. And so with 30 milligram per meter squared weekly low-dose cisplatin, they actually found that the high-dose cisplatin of 100 milligram per meter squared every 3 weeks had improved local regional control, not a benefit to overall survival, but they did have improved local regional control. They also had higher toxicity with the high-dose regimen. So that randomized study was negative, but again, it's criticized because they used too low of a dose of cisplatin. Typically 40 milligrams per meter squared weekly is what is used. There is an ongoing trial, NRG-HN009, that's randomizing patients to concurrent cisplatin, 100 milligram per meter squared every 3 weeks versus 40 milligrams per meter squared weekly. But low-dose cisplatin, 40 milligram per meter squared weekly, does have less toxicity, and it is utilized by many already. Currently, high-dose cisplatin is NCCN Category 1, and weekly cisplatin is listed as an acceptable alternative. But I will say at my institution, we typically use 40 milligram per meter squared weekly fairly standardly, and I think there are many others that do this as well. Okay, we are almost done, but before we end, I just want to mention a little bit of data about immunotherapy in head and neck cancers. Cetuximab is an antibody against EGFR, and it is known to have fewer side effects compared to cisplatin. So there's an old trial by first author Bonner et al., and it looked at treating patients with locally advanced head and neck cancer with definitive radiation alone versus radiation plus cetuximab. The cetuximab was given as 400 milligram per meter squared for the first dose and then 250 milligram per meter squared weekly thereafter with radiation. And what they found is that adding cetuximab significantly improved overall survival compared to giving radiation alone. So the median overall survival went from 29 months with radiation alone up to 49 months with the addition of cetuximab. Now, on a subset analysis of the primary disease site, oropharyngeal cancer patients had the most significant improvement in survival with cetuximab. So other disease sites such as larynx, hypopharynx, they had minimal difference in overall survival. But for the patients that had oropharyngeal cancer, the overall survival went from 23 months with radiation alone up to over 66 months with the addition of cetuximab. Interestingly, there was a later publication in 2010, and it actually showed that patients that had a grade 2 or higher rash from the cetuximab had improved survival compared to patients that had no rash or grade 1 rash. And I just think of that as the rash indicates that the cetuximab is working better. But that is kind of the background data for cetuximab, this trial from Bonner et al. After this trial, there were multiple trials specifically in oropharyngeal cancer, because remember, that is where cetuximab had the most benefit. there were multiple clinical trials that looked at definitive cetuximab plus radiation versus cisplatin plus radiation, with the idea that cetuximab might have less side effects compared to concurrent cisplatin. These studies actually found that there was worse overall survival with concurrent cetuximab versus concurrent cisplatin. So the survival was about 8 to 12% worse when there was concurrent cetuximab. So the big takeaway here is that concurrent weekly cetuximab is an option for patients that won't tolerate cisplatin, because cetuximab concurrently still improves outcomes compared to no concurrent therapy. And then the other option that patients have if they won't tolerate cisplatin is concurrent carboplatin and paclitaxel. But right now, there's no data that we can replace cisplatin with cetuximab. If patients are good candidates for cisplatin, that is still the preferred agent. The other type of immunotherapy that's really a hot topic in pretty much every cancer site these days is immune checkpoint inhibition, right? So PD-1 and PD-L1 inhibition. And there have been multiple randomized clinical trials looking at the benefit of concurrent chemotherapy and radiation with immune checkpoint inhibition. And unfortunately, these have all been negative. So the trials are listed here in this table, HN004, the Javelin trial, Keynote 412. These all randomized patients to standard chemoradiation with concurrent cisplatin, plus either placebo versus immune checkpoint inhibition. And the drugs that were investigated in these three different trials were durvalumab, avelumab, and pembrolizumab, and they were all negative across the board. Most of them had a primary endpoint of progression-free survival, and this was not improved with the addition of concurrent immunotherapy. And so currently, the only role for chemoimmunotherapy is really in the recurrent or the metastatic setting. So the drug that has been approved as first line is pembrolizumab, plus either cisplatin or carboplatin plus 5-FU. So that's what we give in the recurrent or metastatic setting. But if we're treating patients definitively for just kind of locally advanced cancer, there are multiple trials that show no benefit to the addition of immune checkpoint inhibition. So this was a ton of information, so let's just wrap it up with some major takeaways. We talked about head and neck cancer management, and typically patients are either managed with definitive radiation or with surgery. If we're treating with definitive radiation, we typically treat to around 70 gray in 35 fractions, and we can use a simultaneous integrated boost, and some of the dose levels that I gave as one acceptable option are 70, 63, and 56 gray. If patients have clinical T3 to T4 or N2 to N3 disease, we think about adding concurrent chemotherapy. And then remember, there are lots of alternative fractionation regimens. So we can do 6 fractions per week, we can do hyperfractionation, we can do the moderately hypofractionated where we do 70 gray and 33 fractions. So there's lots and lots of different alternative regimens, and these are all used based on physician preference, institutional practice, and so on. We can consider hyperfractionation, especially if patients are not getting concurrent chemotherapy. We can also consider BID radiation, especially if patients are getting retreated with radiation. So these are just some things to consider. If patients go for upfront surgery, then we take a risk-adapted approach. So if they have low risk, then we just observe after surgery. But if they have certain high-risk factors, which we have listed previously in this, then we think about adding post-operative radiation. So the standard dose is 60 gray and 30 fractions, and we can take intermediate and low dose levels to 57 and 54 gray and 30 fractions. If patients have positive margin or extracapsular extension, then we add a boost to 66 gray total. And if we're adding a boost for positive margin or extracapsular extension, then we're also adding concurrent chemotherapy. In terms of systemic therapy considerations, concurrent cisplatin is standard, and we talked about high-dose cisplatin versus low-dose cisplatin, and I have seen low-dose cisplatin used more commonly just because it is thought to have less side effects, and there is some data that it does not have inferior outcomes, and there's also the ongoing study that we talked about. If patients are not a candidate for cisplatin, then cetuximab is an option, carbotaxol is an option as well. And remember, we talked about the negative studies looking at the addition of immune checkpoint inhibition with concurrent chemoradiation, and those were all negative. That brings us to an end, and I hope that this was a useful overview for understanding considerations behind definitive versus post-op radiation when we add concurrent chemotherapy and so on. I wanted to lead with this particular topic and kind of just address general principles of radiation for head and neck because, as we go through the different disease sites, we will uncover their individual staging and treatment paradigms. But for the most part, the dosing that we are thinking about is pretty much the same across all of these disease sites. And so that's why I think this background is very important for us to start with. And then as we get into the disease sites, we can focus on more of the nuances for each individual disease site without spending a ton of time unpacking the radiation and chemotherapy principles per se. So with that, I will hop off, but I really hope that this was useful. Thank you so much for your time and attention.